Hello and good evening and welcome to this ERS webinar. I am Wenche Thorstensen, a Rhinology consultant at the Trondheim University Hospital in Norway. On behalf of the organizing committee and the ERS, I am happy to welcome you to the ERS webinar series with a great team of panelists. We would like to thank Olympus as a main sponsor. This evening, we will be talking about smell and taste disorders, diagnosis, treatment, and outcomes. It is a real pleasure this evening to welcome three colleagues, all with extensive experience. We have Dr. David Lieu from Austria, Professor Thomas Hummel from Germany, and Professor Basile Landis from Switzerland. For those who cannot join this live session, the webinar will be uploaded to the ERS YouTube channel, and it will be available to view at your own pace. Lastly, at the end, there will be a Q&A session where we can answer questions, so don't hesitate to type your questions in the chat function. We will be viewing them, and at the end, we will have a look at them with our experts from the field. Without further ado, I will start a pre-recorded talk of Dr. David Lieu. He is working at the Medical University of Vienna and will give an introduction to olfactory disorders. And I will share David's presentation.
So welcome and good evening, everyone. I want to welcome you all to our next ERS webinar series. Today we'll talk about smell and taste disorders, about the diagnosis, treatment, and outcomes. My name is David Lieu. I'm currently working at the Department of Otolaryngology at the Medical University of Vienna, which is in Austria. And I will start this webinar series talking about an introduction to olfactory disorders. Then Professor Dr. Thomas Hummel from Dresden, from Germany, will talk about the conservative management of smell loss. And then Professor Basile Landis from Geneva, from Swiss, will talk about surgery in olfaction. I want to apologize that I can't be present today at the live webinar because of personal reasons, but I hope that you will enjoy this presentation. So for this webinar series, I have no conflicts of interest. Before I start to talk about olfactory disorders, I want to remind everyone why the sense of smell is so important. So as you know, we need our sense of smell for drinking and eating, for flavor perception. Olfaction is one of the main contributors to flavor perception. We need our sense of smell for cooking. So just imagine you're cooking for your friends and for your family, and if you want to know whether you hit all the flavors correctly, you need to taste your food. So sense of smell also plays a significant role during cooking. Studies have also shown that we need our sense of smell for socializing. It's very important to have a functioning sense of smell when we meet our friends, just to experience everything that they are also experiencing. Interestingly, body odor of our significant other is also very important. Studies have shown that we choose our significant other based on the body odor. We also need our sense of smell for personal hygiene. So for example, waking up in the morning, whether we need to shower or not, that's all unconscious decisions that we do based on our sense of smell. And most importantly, our sense of smell helps us to detect hazardous events from the environment. So just imagine you are at home in the evening cooking, not in the kitchen, and suddenly you smell that something is burnt. So when you would rush over to the kitchen, solve the problem. And all of those things, they contribute to our daily life. And just imagine from 1 second to another one, losing all of these things. So one can definitely imagine that smell loss can significantly affect quality of life. This is just a summary of the previous slide. I like to call it the 6 pillars of olfactory-related areas in daily life. So those are all 6 areas in which we really need our sense of smell. When we look at olfactory dysfunction from the patient's perspective, A really nice study has been published by Andreas Keller in 2013, where he collected patients' experiences after they lost their sense of smell. Some patients, for example, they would report that they're constantly worried about body odor. Some get really angry, some don't socialize anymore after the incident, some are even very depressed. And one of the patient experiences really caught my attention. The patient wrote, "I find it disconcerting that in ordinary medical practice, physicians appear to be unconcerned and that the routine physical exams of elderly people like me don't even include this question." So this should remind us that many patients who seek consultation at our practices have many, many questions that haven't been answered yet. So we need to diagnose them correctly. We need to offer them treatment options and also to inform them whatever questions they have. We need to try to improve their quality of life with this disease. When we look at the sense of smell from scientist perspective, this was a recent PubMed search with the keyword smell. You can see that starting from the 1940s, 1950s, there was a linear growth in publications related to the sense of smell. But with this little virus, 2020, 2021, there was an exponential growth in studies related to the sense of smell. The next years we show, but I think that the interest in the sense of smell will definitely be higher in the next 3 to 4 years compared to pre-pandemic times. So when we look at the anatomy of the sense of smell and olfaction in general, olfaction can be roughly divided into ultranasal olfaction and retronasal olfaction. So ultranasal olfaction is when we smell odors through both nostrils during sniffing. That's the green route. There is also retronasal olfaction. That's when we perceive odors during eating and drinking when we breathe out. So odor molecules reach our olfactory epithelium through the pharynx. That's the blue route. And the blue route and the green route, they significantly contribute to flavor perception. When we look into the nose, we know that most of the nose of the epithelium is covered with respiratory epithelium. We can find olfactory epithelium within the olfactory cleft and also beyond. The olfactory epithelium is special because it has olfactory sensory neurons. Those olfactory sensory neurons allow us to detect odor molecules and is directly connected to the olfactory bulb, which is part of our central nervous system. When it comes to olfactory disorders, we divide them by two big groups. The first group is called quantitative disorders. This is when we perceive the intensity of odors less compared to before the incident. There's also the group of qualitative disorders. Qualitative disorders are characterized by odors that we perceive differently compared to previous experiences. So regarding those quantitative disorders, we can classify olfactory dysfunction either as hyposmia, reduced olfactory function, or anosmia, which is an absence of all olfactory function. Normosmia is defined as a normal sense of smell. When it comes to qualitative disorders, we classify two big groups. The first group is called parosmia, which is smelling odors differently compared to previous experiences, and also phantosmia, which is smelling odors in absence of an apparent stimulus. When it comes to the epidemiology of smell loss, we need to first ask ourselves, how do we define smell loss? The question is, how do we measure it? So as you can see, there are big differences in prevalence rate, either based on whether we ask our patients whether they think that they have a below average smell function, or whether we test them and compare the test results against normative data. So when we ask our patients, about 5% of the general population in Korea would rate their sense of smell as below average. This number is a bit higher in the United States of America, 10 to 23% of the general population would rate the sense of smell as below average, whereas in Europe it's around 7 to 8%. When we test our patients, there have been studies done in Germany and Sweden, and the prevalence is around 20% when we compare the test results of the general population against normative data. So the question about the true prevalence is really hard to answer because the prevalence always depends on how we define smell loss. When we look at COVID-19, you all know that COVID-19 is significantly associated with smell loss. And those are just data that have been collected globally, and newer studies also have shown that there are variations in the prevalence based on the different virus types. But in general, around 40 to 50% of people with or patients with COVID-19 would report symptoms related to smell loss. When we measure olfactory function in those patients, interestingly, up to 98% of those patients would show some degree of olfactory dysfunction when we compare the test results against normative data. When it comes to qualitative disorders, and this was a study done at our institution, we found out that 70% of patients with COVID-19 smell loss that reported to our clinics would have parosmia symptoms. Compared to pre-pandemic times, in patients with post-infectious smell loss, this prevalence rate was around 20 to 30%. So with COVID-19, parosmia was also a significant factor that became very interesting clinically, but also scientifically. There are different causes for smell loss, and this is based on our position paper on olfactory dysfunction. Smell loss can be secondary to sinonasal diseases. So, for example, chronic rhinosinusitis is associated with smell loss in most patients. We know that smell loss can occur as a sequela of an infection to the upper respiratory tract. Most patients will recover from post-infectious smell loss, but some might experience long-lasting smell loss. We know that a trauma to the head can cause smell loss. In theory, we think that this trauma causes a shear of those olfactory fibers and that the signal transduction is damaged. We also know that smell loss can be associated with neurological or neurodegenerative diseases such as Alzheimer's or disease. We know that exposure to drugs and toxins can damage the olfactory epithelium and then also cause smell loss. Some patients have congenital smell loss. That's, for example, when patients don't have an olfactory bulb evolutionary. And also we know that the sense of smell or its olfactory function in general decreases with aging. There are definitely also other possible causes, for example, iatrogenic damage after neurosurgical procedures, tumors of the olfactory cleft, but also multiple systemic comorbidities that can cause olfactory dysfunction. And if we can't find any reason for the smell loss, we would then call it idiopathic smell loss. This slide is very important because this is the relative frequency of the most common causes of acquired smell loss in ENT practices. So as you can see, most of our patients will have some kind of sinonasal disease, which then causes smell loss. We also see many patients with post-infectious smell loss, and interestingly, around 10% of our patients, we can't even find a reason, so we would classify them as idiopathic. Post-traumatic cases only make up 6%, and iatrogenic cases around 3%. So when it comes to the workup of patients with smell loss, I like to refer to the 3 pillars of smell loss patients workup. The first pillar is the history taking. This should be done in very detail. Clinical examination is also very important, and then definitely olfactory testing. So the workup of patients, the history taking, includes many specific questions, which are very important, not only to make the correct diagnosis, but also to for the correct treatment, but also for informing patients as prognosticators. So, for example, we would always ask specific impairments: smell, taste, flavor, phantasmia, parosmia. We would ask our patients whether smell loss, the onset was sudden or gradual, the duration, fluctuations during the day, maybe some sinonasal symptoms that might be related to sinonasal diseases. The past medical history is important: medications, allergies, smoking, which is known to be associated with olfactory dysfunction, toxins, or any family history to neurodegenerative diseases. When it comes to the clinical examination of our patients, we usually scope all of our patients. We check the nasal anatomy. We check whether the olfactory cleft is visible, whether there's something blocking the olfactory cleft. Are there signs of chronic rhinosinusitis or chronic mucosal inflammation, and other sinonasal abnormalities that might only be visible during endoscopy? And before I start to talk about olfactory testing, I want to ask the question, why should we measure olfactory function? Why is it not enough just to ask our patients, how is your sense of smell? Below average, average, or very good? So studies have actually shown that there's a discrepancy between self-perceived and measured olfactory function. And this is why it is so important to measure olfactory function in our patients. So olfactory testing can be done using subjective patient-reported outcome measures, for example, questionnaires, VAS scales, liquid questionnaires, but can also be done based on psychophysical testing. So I've mentioned before, we have the ultranasal route and the retronasal route. So we also have different methods to measure ultranasal olfaction and retronasal olfaction. So olfactory components that we usually measure are odor threshold, that's the minimum concentration of the odor that can be reliably detected, odor discrimination, when we discriminate between different odors, and odor identification. I've put olfactory assessment using electrophysiological studies or magnetic resonance imaging in a bracket because that's usually not used in clinics, but only for research purposes. So those are our recommendations, and the recommendations based on a position paper on olfactory dysfunction. We recommend to test odor threshold and one of the other subdimensions, such as identification or discrimination. And ideally, we test 2 or even 3 of those subcomponents. So we would do odor threshold, odor discrimination, and odor identification. Be aware when using olfactory testing tools that are not cited that much or are not present in the literature, always be sure that those assessment tools are reliable and have been validated for the population. Because, for example, for odor identification, we know that odor familiarity is a big bias. So odor identification So with this slide, I want to end this presentation, and thank you for your attention. If you have any questions, please reach out to me, don't hesitate. And with this slide, I want to invite you to our European Rhinologic Congress, which will be held in June in Sofia. And if you have some spare time, please visit our Austrian ENT Congress, which will be held at the end of September at the Imperial Palace. And I'm really looking forward to seeing all of you there. Thank you for your attention.
And I would like to thank David for a wonderful presentation. So the next panelist is Professor Thomas Hummel. He is a professor at the Technische Universität in Dresden and has an extensive number of publications in this field. He has a talk about conservative management of loss of smell. Welcome, Thomas.
So thank you very much for the invitation. It's really a pleasure for me to talk here today. Let me start here to share my screen. And this is what I wanted to start here. Sorry, what's happening here? Sorry. to share it. Okay, so my task is here to talk about treatments for olfactory dysfunction. So first of all, to my person, who am I? You mentioned this already. So my name is Thomas Hummel. I work in Dresden, in Germany, and this is where we are on the planet, on this little dot. And actually between, well, this is Austria here somewhere, and this is where Geneva is somewhere on the place. So like we're all closely together, and this is where you see Dresden is between Berlin and Prague. So in the middle of there, this is where we work. We have an olfactory clinic where we see patients with olfactory loss, and this is what I'm going to talk about today. So olfactory loss in chronic rhinosinusitis, how is this treated? You all know this. So first of all, there are several options. One of them is systemic steroids. They work very well, but they have side effects. So we can only use them shortly, mostly also for diagnostic purposes. They work extremely well. But then typically you would sort of switch them for topical administration of corticosteroids. And this is a problem because several studies show convincingly that topical administration of steroids do not really work. Why is that? Because the steroids, probably when they're used with a regular spray, they do not reach the olfactory cleft. That has been already shown, like in the year 2000, very nicely put together by Cobber and what they from Scotland. And what they did here, and also republished them by Benninger and colleagues. And what they did here is they applied these drops in various positions, like head reclined and head down forward. And what you see here on the bottom is that this is the distribution of the drops inside the nasal cavity. You see which areas of the nasal cavity are touched when the drops are applied in these positions. And as you notice, none of the position actually helps to bring drops to the olfactory cleft. This is a because the simple thing is the nasal filter. So this is why a different way would be the Kaiteki position. Kaiteki position is shown here. When people lie on the side and they apply the drops to the nasal septum from the top, this you see the situation before drop administration. This is after drop administration. So this works very well. When people apply drops on the side position, they tilt the head slightly, and then they apply the drops from the top to the septum. Then actually the drops stay in this position for half a minute. Then the drops can run up to the olfactory cleft and be effective. Another way to be effective is here like a longer applicator, as you see here, like the normal spray is exchanged with this longer application device. And with that, one can relatively easily reach the olfactory cleft. You have to just put them into the nose for that much, for about 3-4 centimeters, bypassing the lower turbinate. And what you see here is this is the effectivity shown with the dashed lines. Is significantly more effective in patients with olfactory loss compared to a regular nasal spray. So one other thing would be to possibly put the sprays into the nasal lavage fluid. So that could also be a different option to bring steroids to the olfactory cleft. So steroids very effective, but it's not so easy to bring them to the olfactory cleft. When it comes to chronic rhinosinusitis, of course, biologicals are very important. There was a very nice review recently by Joachim Moyol from Barcelona and colleagues. What he showed here very convincingly is in this review that here you see at the bottom the response curve to placebo, and here on the top you see the response curve to dupilumab, which seems to be the most effective drug, most effective biological when it comes to chronic rhinosinusitis. And what you have here is with polyps. And what is here is that after 2 days, already similar to systemic steroids, after 2 weeks, sorry, it has very strong effects. So similar effects are seen also with systemic steroids. So, but systemic steroids, of course, have much more side effects compared to dupilumab and other biologicals, although one must say that they're also not completely without any side effects. What can we do? So this is chronic rhinosinusitis. What can we do in post-traumatic and post-viral olfactory loss? This seems to be more difficult. First is counseling is very important because we don't have so many things that we can offer the patient. So it's very important to tell the patients which factors are determining the outcome of spontaneous recovery or of recovery as such. One is olfactory function, so the outcome. Age is a factor. The younger people are, the more likely that also olfactory function will recover. And the longer the olfactory function has been lost, the less likely that it will come back. There's also two other factors. Smoking is not good. So I typically talk to my patients. And actually last week I had a patient who quit smoking because I told her to do so because she improves her chances for recovery. But it doesn't happen very often. Then there's parosmia. Parosmia could, there are a couple of studies indicating that parosmia could be a positive factor. And people with parosmias seem to recover better than compared to patients without parosmia. What might work in terms of conservative treatment? There are calcium chelators, sodium citrate and other calcium chelators, vitamin A, there's omega-3, there's platelet-rich plasma, there's palmitoylethanolamide and luteolin, there's also platelet-rich plasma. So a couple of things that one can do, and of course, olfactory training. I will try to talk about this very briefly in the next minutes. First of all, calcium chelators. There's sodium citrate and other calcium chelators. We had a couple of studies on sodium citrate based on a study from Greek. And what we had here is that what we showed in all these studies, also together with Carl Philpott, Katie Whitcroft, we saw here that it has a moderate effect on olfactory function. And in one study, we found that it has a strong effect on odor phantoms. So when this sodium citrate is applied to the olfactory cleft, then it seems to improve odor phantoms. But one has to keep in mind that this diagnosis or this symptom is based on subjective ratings. This is based on what patients tell you. So I would love to see also a replication of that study. There's more work from calcium chelators that comes from Egypt. There's actually Dr. Abdelazim from Egypt and colleagues. They have been very active in that. They tried a number of drugs, of substances that they applied to the olfactory cleft. One of them is tetrasodium pyrophosphate. There's sodium gluconate. They use that in people with longer lasting olfactory loss after COVID-19. Actually, olfactory loss was for 3 months minimum, I think, and they observed them for 1 month and saw a moderate improvement, but it was significant compared to placebo. In a different study that they did in patients with very short period with post-COVID olfactory loss, after only like for a couple of weeks, and they used nitrilo-triacetic acid trisodium salt, they saw very strong effects, but you have to keep in mind that also the spontaneous recovery in this group of patients is very high. So this all comes out from this one group, and it would be nice if these studies could be repeated. These are double-blind studies, randomized clinical trials. What about omega-3? Omega-3, there is one study by Carrie Yan and Zara Patel and colleagues, but they tried omega-3 in patients after neurosurgery or basal skull surgery. And what they had here is they saw a significant effect on olfactory function. We tried that too in post-viral olfactory loss, and what we found here was a moderate effect on odor thresholds. So it does something, but the effects are not really overwhelming. So omega-3 could be helpful. We used in relatively high doses, like 2 grams per day for a period of a couple of months. Then the topic of vitamin A, that could also be helpful. We did a study a longer time ago, also in a mixed group of post-viral and post-traumatic olfactory loss patients. And what we had here is that a topical vitamin A, not systemic vitamin A, this is not what we tried out. It has been tried out in the 60s very effectively. So in 70s very effectively. What we had here is vitamin A produced a significantly better effect than what was seen in controls who did not receive the vitamin A. So, but the effects were also not overwhelming. They were there, but not overwhelming. What about platelet-rich plasma? Has become a relatively rich hot topic. Platelet-rich plasma has been tried by a number of groups. There's, for instance, Jérôme Lechien from Belgium. What they did here, they injected PRP into the middle turbinate, and then they found a moderate effect on the TDI score measured with the sniffing sticks. So it was significant before and after, but there was also no control group in that study. The study by Carol Yan and Sarah Patel and co-workers was in that respect better. It was a double-blind controlled. It was a controlled study. They also had a placebo group in there, and what they found here is that there was a significant improvement in the TDI score measured with the sniffing sticks. So the overall TDI score improved from before the study, after 3 months of the study, after a series of injections. So what they had here was significant effect on the TDI score, with that was sort of accompanied by the ratings of the patients, but this was not significant. So platelet-rich plasma could be an option, but the effects also are not super strong. So it doesn't work like a charm. Then palmitoyl ethanolamide plus luteolin. Palmitoyl ethanolamide and luteolin comes from a group from Italy, so led by Arianna Di Stadio. What they had here, a couple of studies with these drugs, with these nutritions that seem to support neuroregeneration and also radical scavengers like luteolin. And what they had here is that it had an effect on effective function in this placebo-controlled study, or in this controlled study. What they had here is that in controls from before to after, there was a slight improvement, but not significant. And it was stronger, was significant for the palmitoyl ethanolamide and luteolin group. So there was clearly an effect there. But also the effects are not extremely strong. We also have to see here that in this study, the placebo group had started from a significantly lower level compared to patients who received the PA and the luteolin. So finally, not finally, but also steroids. What do they do in post-viral olfactory loss? Is there a role for them? Yes, there is, or there could be. This idea was sort of fueled recently by a study from Finlay and colleagues and the group around Brad Goldstein. And what they had here is they showed that in patients with post-COVID, there was signs of an ongoing lasting inflammation. And this is the basis to use steroids or like anti-inflammatory drugs, so which could be helpful. However, when we do that, when we try steroids applied properly to the olfactory cleft, we do not see a difference between patients who do not receive steroids and patients who receive steroids. So this was like, in our hands at least, we did not see the effect. Of course, you can say it may be only so, maybe only true this long-lasting inflammation in a specific group of patients. That could be so. I think the future has to tell whether anti-inflammatory drugs can be helpful, at least in a subset of these patients. What about olfactory training? Olfactory training, I think many people agree that olfactory training can be helpful. The effects also depends on studies. Most studies show that there's a significant effect, but there are also the studies showing that there's no effect. What is the principle of olfactory training? People are supposed to smell 4 odors, like twice daily for 20, 30 seconds each. They shouldn't use household odors, but get these odors from grocery and or from like oils, like odorized oils, and sniff them 30 seconds each for a longer period of time, for a couple of months, so not just for 2 weeks. And the effects there are nicely illustrated by this work by Ioannis Konstantinidis from Greece and his colleagues. And what he showed here is that was before the pandemic, that in patients with post-viral olfactory loss, more than half of the patients, more than twice as many patients improved in terms of olfactory function. And this was also similar in patients with post-traumatic olfactory loss. There was also a significant improvement that could be found. These effects were long-lasting. What you see here is these are the effects when you followed up these patients over a period of 56 weeks. Here, like patients who didn't do anything, they didn't do olfactory training. That's the bottom curve. There's slight improvement, but not very pronounced. Then here you have the curve of patients who trained for 16 weeks and then they stopped, so they stay at the same level. And patients who continue with the training, they also improve even further. So these data seem to indicate that olfactory training seems to be helpful, even when it's done for a longer period of time. It also has been shown for COVID-19, work by Aytu Altundag from Istanbul shows that olfactory training seems to be helpful. That's what's indicated here. Before training and after training, patients with post-COVID, with COVID-19 of associated olfactory loss, show an increased olfactory function. Meta-analysis put that together, also showing that olfactory training seems to be helpful there. What does it do? What's the effect of olfactory training? It works at a peripheral level. That has already been indicated in the 90s. So what always says in the last century. So what's shown here is by this work by Steve Youngentaub and Paul Kent. They worked at the epithelium in rats. And what they had here is with these voltage sensitive dyes. That was a situation before they exposed their rats to odors. And this was the signal that they received after exposure to odors. So a significant improvement, indicating that it's something that's happening at the level of the mucosa when these rats are exposed to odors. And similar results also come out from Kim and colleagues. They also worked in mice. And what they had here is that they looked at olfactory receptors and other factors, and what they saw impressively that one of the receptors that they looked at showed a significant improvement only to olfactory training. And this was also supported by behavioral studies where they saw only to olfactory training, not to steroids, not to other treatments that they tried, or not to other conditions. They saw a significant improvement there. So again, olfactory training, exposure to odor seems to do something at the level of the periphery. We also see similar things in our mice, right? Similar things together with Federico Caligari and Vittorio Avaro. And what we see here is that actually when mice are exposed to odors, that the number of stem cells, which is found here at the bottom, these are these light green structures there, they seem to increase when mice are exposed to odors. What does it do on a central nervous level? In humans, it increases brain volume, it increases brain function, so responsivity increases, and increases also brain connectivity. So olfactory training has a number of effects, probably at the level of the periphery, but also at the level of the brain in humans. What do we do? Now I showed you laid out all these many different options that we have. What do we do in our clinic? We do olfactory training. This is what basically most of our patients get, at least those with post-viral and post-traumatic olfactory loss. Then we often try topical vitamin A for 4 months. Those side effects are not really there, and we see this effect in our studies. We currently have a trial with palmitoyl ethanolamide and luteolin, and we're very excited to see whether we can replicate what has come from Italy. And we are working on a trial on platelet-rich plasma, but we will see how this pans out and what our ethical committee says to that. So this is what we do. Of course, you have many different options, and you have to select what's best for you. Some future here, what can be done in the future? Possibly conservative treatment, not really. Olfactory implants, they are more on the surgical side. That's based on work not only, but also based on work by Eric Holbrook and co-workers from Boston. And what they had here is they stimulated the olfactory bulb with this electrode and found that these patients have olfactory percepts when you stimulate them electrically. So that's the basis for possible electrical implants or olfactory implants. And what's another option could be transplantation of the olfactory epithelium. Maybe Professor Landis will talk about this after my presentation. There's some very convincing work in mice and rodents by Brad Goldstein and Sarah Kortenbach and other people, and Rupa Chaudhary. And what they had here is that it's possible to do that in mice, and they show that on immunological and electrophysiological and behavioral levels that this could be working. And with that, I'd like to finish. Thanks for inviting me here, and I hope I was halfway clear. If there are any questions, please come back to me. I'd be happy to answer them. Thank you.
Thank you very much, Thomas, for a really nice presentation. So we will move on to our next panelist. And it's a pleasure for me to introduce Professor Basile Landis. Basile is a professor at the University of Geneva and head of the Rhinology department. And he will now talk about surgery in olfaction. Please, Basile.
Hello, thank you very much for giving me the opportunity to, no, sorry, that is the wrong thing. So, sorry. Can you see my presentation now? No?
Yes, now we
it
see
works.
Yes,
Super.
it works.
Okay, so thank you very much for the invitation. I hope I can also bring some new insights to the topic of olfactory disorders. Now, when I received the invitation and this title, I was kind of, I had a few associations what to talk about, and where is the role of surgery when it comes to olfactory disorders? You have seen many things on epidemiology, talked by Professor Liu, and it's a wonderful overview of how we can treat olfactory disorders, mainly by medical treatments, as we have just heard. Now, surgery in olfactory dysfunction has its role to play, but I would say it's a moderate role, and I have no disclosures. I elaborated the plan, so I would spot on 3 things, and as you can see with the size of the writing, I will focus on olfactory disorders related to sinonasal problems. As you have heard, sinonasal problems, I guess most of us are ENTs who are listening, and we struggle with a disease that is very prevalent, and many of our sinonasal patients do have olfactory disorders. Now, it's important to keep in mind that treating the sinonasal problem often brings back or improves olfactory function. We have heard that by medical treatments, but also surgery can do that. So I will focus mainly on that topic. I will also talk about qualitative olfactory disorders or distortions, or let's turn it like parosmia and phantosmia, which most of us now know from COVID. What is the role to play for surgery in these patients? And then some special situations, thoughts I have about what I could see in the recent years to develop, to do surgery around the olfactory area. So I will not repeat what David showed us and also what Thomas showed us is probably olfactory disorders are located or mostly associated to ENT, not because we are smarter than the neurologists, but because the biggest provider of olfactory disorders, despite COVID, is a nasal disease. So if you have a problem with your nasal cavity, you're likely to have a neuronal disorder or a disorder of the olfactory function. And you probably end up sooner or later to see an ENT. So when I'm talking about that, I'm talking about people like that. I think most of us do have patients like that, and we sometimes wonder, how is it possible for them to smell? How is it impossible to smell, although they would have a patent olfactory cleft? So it's easy to understand. It's very mechanical. So if you have these nasal cavities full of inflammation, and especially, may I show you this, the area of the olfactory cleft is this very long and very narrow space where odorants have to go into to reach the olfactory epithelium and to elicit an olfactory percept for us. Now, let me drive you through the sinonasal problems, because not everybody that has a sinonasal problem has an olfactory disorder. What does that graph show you? On the right side, you can see the bars of normal people, and it's labeled as a test score. So high bar means a good test result. We have just the helicopter landing on the hospital, so maybe you hear that. It will not take long. So let me show you the AC group. What is that? These are people who have allergic rhinitis, and you can see that they have a nasal condition, but they do not have a substantial olfactory deficit. So rhinitis patients may have fully normal olfactory function, but they may also complain of something. It looks very differently if you go to the green people. These are CRS patients, so chronic rhinosinusitis patients, either with or without polyps. And as you can see, compared to the control groups, they're heavily affected. So these are the patients we will focus on when we treat the chronic rhinosinusitis, and we have olfactory function in mind. As you all know, and I would like to refer to the APOS paper, when it comes to CRS or rhinitis, the first line treatment is not surgical, although most of us may love to do surgery. When it comes to olfactory function and when it comes to CRS, which is an inflammatory disease, first-line treatment is medical, and surgery has its place only if this inflammatory condition is insufficiently controlled by the medical treatment. Now, what is that, I would say, rather old slide, but still very, very actual slide, is the mean score of symptoms when it comes to the main symptoms of CRS, so facial pain, nasal obstruction, discharge, and smell disorders. And the arrow indicates the point where the surgery takes place. And what you can see is that with surgery, with functional endoscopic sinus surgery, we do have a nice control of all the symptoms. Nevertheless, the least controlled symptom is the green, the light green, the light blue bar is olfaction. So we have little control or lesser control on olfactory function with our even wonderful surgeries tools we have now on olfaction than we have on nasal obstruction. So why is that? That may be, and I'll come back to these people, these scans, that may be due to the fact that we often restrict surgery to the sinonasal cavities, to the ethmoids, the bigger sinuses, but rarely go into the olfactory cleft. And the inflammation in the olfactory cleft is not often addressed by surgery. So if I sit in front of a patient who is eligible for a CRS surgery, functional surgery, and he asks me, okay, I'm fine with surgery, I'm looking forward to have better breathing, to have a better management of my CRS, but doc, how are my chances to get a better olfaction? So that is still a very tricky question, and I don't know if many of you can answer straightforward. So there is a little bit of literature out there where you can have hints pre-operatively how to help these people, counseling them whether their olfactory function would be best. So out of these 3 scans, you had a while to have a glance at them, whom you think will perform best. So, and one thing is the opacification of the olfactory cleft on such a scan. You can see on that very nice publication, which is also from a while ago, that patients with mild opacification or non-opacification of the olfactory cleft have a better chance of having norm osmic state pre-operatively, and also a better state of recovering olfactory function, which is not the case if the cleft is heavily obstructed. So in this particular case, it will be the patient at the right side where you will be the most tempted to say, yeah, listen, your olfactory function should improve if it is not already fine, because the olfactory cleft is fully patent. Is there any other parameter that would be helpful to counsel a patient and to predict the success of olfactory outcome after a surgery? Yes. One is to administer oral steroids. What do you see on that graph? These are people that have been followed up and asked whether olfactory function improved after surgery. Now, all of them have been given a few days of oral steroids, and you can see that in the violet bar. The violet bar are the responders, so they would get some oral steroids, wonderfully respond, having a recovery of olfactory function, and that recovery seems to hold very long time. If you see, that's the months after surgery. Whereas the non-responders, patients who would not respond positively even to oral steroids, would also have a poor outcome when surgery is done. Now, a similar study has been done by Thomas and colleagues, where it was not asked but measured, and you can see on the y-axis, this is 32 is a fairly good result, 16 is a very poor result. Preoperatively, you can divide 2 groups of people: those who respond to oral steroids, the black bars, and those who do not respond. And you can see on the time scale, after surgery, the responders would maintain a very suitable olfactory function. So together with the olfactory cleft opacification, a steroid trial preoperatively would give you a hint whether your patient may recover olfactory function sustainably after surgery. Now, these two elements, olfactory cleft opacification and steroid response, show us that it is not the surgeon that really is the key to success, but is the disease. And these are our data. We subdivided the roughly more than 500 people who had chronic rhinosinusitis with polyps, that's on the left part of the graph, and without polyps. And I would like to invite you to have a look to the pattern of distribution. So blue is anosmic, red is low, hyposmic, and normosmic is green. So you can see that with polyps, you have much more anosmics, whereas without polyps, the normosmics are more. Now, after surgery, what you see, the pattern does not change, okay? And that is something you can find in other studies. So even if you are like an excellent surgeon, the pattern, the basic pattern of the disease will not be influenced. And that is unfortunately a kind of a summary for olfactory function in CRS disease, is that it's not so much the surgeon that influences the outcome, but the underlying disease. So that is the conclusion of my first part, is that olfactory dysfunction is more pronounced in CRS than in rhinitis. So it's not everybody has a nasal condition has an olfactory problem. The more the inflammation is pronounced, the more the olfactory function is impaired. It's the disease state, and more than the surgeon, that influences olfactory function pre and also post-operatively. I know the temptation for surgeons is also always very high to think that we can fix it with the knife, but I think in this case we should be a bit cautious. Now, you can also, as summarized, you can also give some predictive values on how people would develop olfactory function postoperatively with these two very easy indicators, steroid trial and olfactory cleft opacification. Now, let me lose a few words, and these are my last minute slides, is on olfactory dysfunction distortions. So you know that we have parosmia, it's a triggered distortion. That's what we have seen a lot now with COVID. So people would smell something, it has not no smell, but it has a bad and the distorted smell. And phantosmia, it's something that is very prevalent, mostly in post-infectious olfactory disorders, but also in other conditions. Now, both conditions have a very high spontaneous recovery rate. And so you should withhold from doing surgery in people who have parosmia or phantosmia within at least the first 2 or 3 years. Don't do anything. The likelihood that it goes away is very high. Now, maybe some of you, at least in the specialized outpatient clinics for smell and taste disorders, we encounter people who I would label as tenacious phantosmia people. That are people that reliably report a bad smell coming from either one nostril or from the other one. It's coming and going, or it's always there. It can be sometimes you hear weird stories, people like sneezing and it starts and it will last for the entire day until they go to sleep and things like that. So these are often very desperate patients willing to do everything, which is a bit dangerous if you enter into a surgical waiting room outpatient clinic. So now most of the times these people had super workup, it's idiopathic, so there's no obvious reason why they would have this phantosmia. It's like a tinnitus of the nose. Now, there is not so much literature out there in these cases. It's quite controversial. Some people could manage to treat these people medically, again, some with antidepressants, some with local anesthesia. Now, out there are also a handful of reports how to operate on these patients, and I would be very cautious to take these few reports as granted knowledge. So some people would resect bulbs. So of course the patient has no phantosmia anymore, but he has no olfactory bulb anymore and no function. Then some colleagues, and I must say these are all colleagues I respect with a lot of knowledge, and they selected their patients very carefully. They went on with these patients to peel off the olfactory mucosa. So what does that look like? You have on the left side, you have a magnified view of the olfactory cleft, the septum, the turbinate. and here the olfactory fibers that are dissected, and you can see the olfactory mucosa is peeled off. So that basically means if you peel off the olfactory epithelium, something a surgeon does not like to do. You know, you destroy something. Now, some of the authors analyzed the epithelium and came up with the fact that in these phantosmia patients, they could find like neuromas. So that would be like scars of the nerves. It's still open question whether that is the cause of the phantosmia, but it's at least interesting if such cases are done. I think it's important to work up the material. Now, what is the success rate of this kind of surgery? So the success rate for phantosmia cure is intermediate. It's quite good. People who came to that step could be cured from phantosmia, but keep in mind it goes along with anosmia. So most of these reported cases where there was only one side that was affected and only one side was operated, and this side did not recover. So the people had no phantosmia anymore, but they had no smell anymore on that side. So I think it's a very careful balancing of side effects and the benefit you can have. I personally had so far, I've seen many of these patients, but we never went to the surgery because for different reasons. I think losing olfaction fully is something we should really think about. Now, for unilateral cases, this kind of surgery may be discussed, but I would really warn to select the patients very carefully, and personally, although I consider ourselves a center with a lot of patients, we have yet not done that. Now, special situations. That's my last thought. Recent years brought some funny publications, and you can see the scanners on the left side. These are people with olfactory clefts that are obstructed either through extensive pneumatization of the middle or sometimes the superior turbinate. So the olfactory cleft will be completely collapsed, or as you see in the lower picture, like scarring or opacification. Now, the pictures you can see on the left it's a very mechanical or mechanistic thinking that we could just dilate these clefts. And looking into these pictures looks very tempting and appealing. These publications also claim that patients would improve olfactory function, although the smell testing is done in sometimes a bit incomplete way. Now, we have been a bit influenced by this kind of publications and selected a few cases and have done that on sporadic patients. And I must say, I'm a bit disappointed. That's my personal viewpoint. I find that very appealing and very tempting, very mechanistic approach, interesting. But I must personally say my own experience is that although you dilate properly, it doesn't really work. So I let that open to the discussion, but I think it's important to mention that, because that is also something, it's a potential source of harm for patients. You can also harm the olfactory cleft by doing too much manipulation in that area. And finally, a disease that is known now for the last 20 years, I would say, the RIA, the respiratory epithelial adenoid hamartoma, which probably most of you know, or if you don't know it, it's a kind of a proliferation of glandular tissue. It's benign, and it's mainly located in the olfactory cleft. You can see it enlarges the olfactory cleft. Now, again, many of these patients, not all, but many of these patients have impaired olfactory functions. Sometimes they complain, sometimes they do not. And the temptation to go in and do surgery is quite high. Now, is there some literature out there? Yes, there is. Some French colleagues had a closer look to what to do. At least they were brave enough to go into the olfactory cleft and take off these RIAs. You can see, I would like to stress the red bars or the red lines. You can see that this is a removal or a biopsy. So if you go for a full removal, so this patient here, for instance, has a very poor olfactory function after full removal of that obstructive proliferation, you can reach a bit better olfactory function. Now, that is not in the original graph, but I allowed myself to put this scattered line, because the scattered line means normal. It's the threshold for normal olfactory function. And when you can see all the patients with these RIA that have been selected had really very bad olfactory function, and any kind of intervention just brought them a bit better, but these patients still remain poorly with a poor olfactory function. So I would just raise the question how mandatory and how useful it is to restore olfactory function in this kind of situations. I'm not against it. We have done that in a few cases, but again, I would take that with a lot of caution. There's always the potential to do some harm if you work around the olfactory cleft. Now, that is a summary for the RIA. Surgery may help a bit olfactory function, but keep in mind these patients already have lower olfactory function. So I come to my general conclusion, like the overview of all the things I told you so far. So I think over the years, I'm a surgeon as well, and I like to do surgery. And so, but I would say that olfactory outcomes in cases where surgery is indicated anyway, you will do surgery for a CRS that is not controlled, then often the byproduct, which is called olfactory function, may be improved. You have little influence on that as a surgeon, and it's difficult to predict. Now, the other way around, if you have surgery or you intend to do surgery because of a sole symptom a patient has, like a distortion or a cleft opacity or a RIA, keep in mind the literature is very scarce. It's not more than a few case series or case reports, and I would really keep in mind, or I would like to warn people that surgery in such cases should be always wisely reflected, because you do surgery around a sensory system, and there is potential benefits, as these publications may suggest, but there is also potential damage, and I think you should keep that in mind. And with that last slide from Geneva, it's unfortunately raining today. It's not as beautiful. I would like to thank you for your attention.
Thank you, Basile, for a very nice presentation. I would like to start with a few questions from the audience. The first question is about evoked potentials. Does anyone have something to add to that? Do you use that?
What is the question?
It only states, what about evoked potentials?
I think it's which is the place of evoked potentials in the workup. I think it refers to David's talk.
Mm-hmm.
For us, I can state it for us. It's time consuming, but it's very reliable. It needs some expertise, and we keep it for medical legal cases and research. It's not routine practice.
Yeah, right.
I would not dare to recommend it as routine practice.
True. We got another question about stellate ganglion block. Does anyone have any thoughts about that for treating anosmia?
Like, we don't have any experience with stellate ganglion blocks, but it's we have been discussing this actually during lunch here, and the conclusion was that we did not know the concept of that, so why it should work. So in the studies for that, if there are any, so apart from case reports, they so I would not know a convincing study in this area. Maybe Basile knows anything, but I'm not aware of any.
No, I must honestly say, but maybe I'm not knowledgeable enough. I don't even know where it is used. So, is what would be the indication?
the indication has been said that it's good for parosmia. That's
Okay.
actually was here in the United States. It was like 2 days ago. It was like a surgeon from a place. So he said, this works like a charm, more or less. That's what I heard. And this sparked a lot of public interest. And so so many people who are desperate with olfactory loss then all flock to this potential option.
But may I pick that as an opportunity to underline what I really mentioned during my talk. If you are facing people with distortions, especially people who have long-standing distortions, the profile of these people is that they are so desperate. They usually have seen many people. I think it's the same for headache patients. So you come up with patients who have done extensive medical tourism, and I would say it's bad luck if they end up in somebody's hands who uses them as study animals, you know, because it's very different. It's easy to propose any kind of injections without any solid hypothesis to a patient who is willing to do everything. And I think that's a certain danger. We encounter that with phantosmia patients. I would really withhold from that temptation.
Yeah, I think I also would agree to that. It's like the idea is as long as you don't connect it to a study, then it becomes problematic. What's missing in this area are studies.
We got another question. What about the added value of oral corticosteroids in the post-viral loss of smell?
There's the studies that are out there, they're not really convincing. So just kind of, they could be of value, could be not. That's what I was trying to point out in my presentation. There's been recently this work by Brad Goldstein and colleagues, what they were the signs of ongoing inflammation in post-COVID patients. So that could be the rational basis for applying anti-inflammatory drugs. However, when you look across the different studies, steroids have not been convincing. Then you can say, oh, maybe it's a subgroup of these patients who have this ongoing inflammation, but then our studies are missing again. So it's not that I try to want to repeat this all the time. It could be helpful, but maybe in a very specialized group of patients. So, but this needs to be identified. I would not apply to every patient. So please.
May I add some? I fully agree with you. If the goal is to treat neurosensorial olfactory loss due to a viral infection, I think that is useless. I would say you have more side effects from the steroids. We're talking about oral steroids than any hope of benefit. Now there is a subgroup of people with post-viral infectious loss who probably have some remaining concomitant inflammation. You don't forget that 20% of the people have criteria for rhinitis or CRS. And that gets more prevalent in the population. So if somebody who has already a CRS gets a viral infection, loses olfaction, maybe this CRS, we have seen that of COVID, also enhances a bit the ground inflammation of this person. So, and there is a good work from Ioannidis Konstantinidis. They took all their group of post-virals, gave them steroids, and they figured out that like 15% had an increase of olfactory function. And their conclusion is that these people do not increase, it's not neurosensory loss that has been addressed with steroids, but it's concomitant inflammation. And we also now and then see that. But yeah, a person may have two things. That's what I mean.
I will move on to the next question. So any one of you have experience with steroid diluting devices designed to be placed in the olfactory cleft?
Sorry, steroid diluting devices?
Yes, that you put into the olfactory cleft. Has that been used for treating olfactory dysfunction?
I think there was one study from a Japanese group, and they injected steroids like with a retarded release into the olfactory mucosa close to the olfactory cleft, and they saw very nice effects because I think what they treated was patient with chronic with inflammatory causes, so that worked very well. But this, as far as I know, is only one study. So
But it's an interesting issue is how to administer topical steroids. And I think if your main concern is olfactory function, then you should give the patient all the chance that the local steroid you administer really reaches the olfactory cleft. And there are different devices out there published that may be like squirt systems like Thomas's group published, or like nebulization or drops or washes. You can increase the amount of local steroids which reach the olfactory cleft, and now and then it works better than if you just simply give a spray.
Thank you. And the last question of this webinar would be, is there a role for zinc supplements? Do you think that? What does the research says about that?
There's one, if I may say something, like in patient with post-traumatic olfactory loss, there's a study from China saying it's double-blinded in 200 people, says it has a significant effect on placebo. The study has not been repeated, and all the previous evidence for that zinc would be helpful in post-traumatic olfactory loss is negative. So that's sort of a solitary thing. However, having said that, like in post-viral olfactory loss, there was just like last week, there was a study from Japan, from a group of around Erin Mori and colleagues, and they see that the zinc level in plasma, that this is related to the outcome, to the prognosis of patients with olfactory loss. So zinc seems to play a role there. It's still not clear what it does in olfactory function, but maybe it's a role there. So it also has some historical aspects that zinc has always been tried with different success rates. So.
Thank you.
But the study from Japan, I think that's interesting. So it shows like interesting results. And of course, this study from China, but it would be nice to see it repeated.
Well, I would like to close this webinar with these last questions and thank the panelists for fantastic talks. I would also like to thank the European Rhinologic Society for their support, and also thank Olympus for sponsoring the webinar seminars. And we're looking forward to seeing you all next week for a webinar on obstructive sleep apnea. I wish you all a nice evening. Thank you.
Thank you very much. Bye.
Thank you. Goodbye.